All right. Good morning, everybody. Welcome to Office Hours. I am your host, Coach Joshua. So good to be with everybody. So, if you don't mind, turn on your camera so that I'll be able to see you. And we'll just jump into, well, first of all right, if you can, turn on your cameras. Hey, Becca, good morning. And Kayla, Brian, good morning, everybody. And for those of you who are watching this in the replay, um, one of the things I wanted to start off with, you probably saw some announcements yesterday. We have we now have like probably over 20 different exams. Now, some of them you don't see yet, especially some of the final exams, but we've created multiple types of exams for EMT, um, for advanced EMT, for paramedic. We have diagnostic exams, final exams, but then there are topic specific exams, especially at the paramedic level. So there's some on like endocrine emergencies, cardiac, EKG, shock, acid base. So as I was going through some of you did the initial diagnostic exam, and one of them we kind of got rid of because it was probably a little too easy. So I just eliminated that one completely because I want to make sure that we're giving you something that's challenging, so that we improve your likelihood of passing the real test. So what I'm saying is you have lots of exams loaded into the class marker platform. All of you have been enrolled in class marker. If for whatever reason you didn't, well, check your email. You should have an email from class marker. If it ended up in your spam, promotions, or junk folder, just kindly move that to your inbox because that has your login information and you'll need that to be able to access the platform. But what I want you to do is kind of space out those exams. Don't do them all at once. Space them out over 2 or 3 weeks. And I will be able to have access to it to be able to go back in, see your results, see kind of the patterns. And the good thing about all of the exams kind of being in one place is I will not only be able to see like one individual exam, but I'll be able to see patterns over all the exams. So for instance, if I say, oh, you keep missing Vaughan Williams classifications or you keep missing acid base type questions, then I'll be able to kind of focus with you and kind of improve your weak areas that are topic specific. So everybody should have access to that. If you don't, let us know. The other thing I wanted to mention is, oh, so I also made an announcement yesterday about there's a form that I want everybody to fill out. If you haven't tested yet, even if you just recently enrolled in the program, I want everybody to fill out that form. Now, for those of you who are here today, or just show of hands, for those of you who are on with me now, did you already fill out the form? Okay, so here's what I'm gonna do. I'm gonna actually drop this in the link really quickly. I'm gonna drop it in the chat for you now. And all right, bear with me one moment. All right, so I'm gonna drop that link in the chat. I want you to pull it up, go ahead and open it, and you can either work on it now or it'll probably take you 5 minutes. You can work on it now, or you can at least go ahead and open it before this Zoom window closes so that you have access to it. I've also dropped the link. I will also put it in, it's not there yet, but it will go under forms inside of school. But the reason for this is for us to get the most accurate information in terms of, okay, when is your test date? What's holding you up? Where do we need to improve? Things like that. We will review all of that. So right this second, 17 people have submitted it, but I sent it out to, I think, 85 people. So make sure that you go ahead and submit this right away. And then the other thing that we're starting to implement starting tomorrow is we will have weekly accountability meetings. So, and the whole purpose of that is just to hold everybody accountable. So I want to kind of hear, all right, what are you going to work on over the next 7 days? And I want you to announce it to everybody so that we can hold you accountable. Because what happens is I pulled all the data yesterday. We built a whole new dashboard to be able to track every single person. And what we found is we had some people who've been with us more than 120 days already, and they still haven't tested. And in fact, there were 11 students who were still kind of in that plus 120 day plus window. And we don't want that to happen. We don't want anybody kind of sticking around more than 90 days. It's not that we're trying to get rid of you. It's just that when you started with us, your goal was not just to like take a course, your goal was to get the information that you need to be able to apply it and go past the test. And so we want to help you do that. And so our team has really been working overtime, just putting together lots of resources. You should have, I mean, and one thing I want you to know is, for instance, the people who started with us, let's say back in cohort 1, they didn't have any of these resources. They only had just cohort 1, just the videos themselves, and many people pass with just that alone. So it's not that you need all these additional resources, but if you do, they are available to you. Okay, don't see the link? So the link, I just posted it in here. Let me drop it again, but it's in the chat. So inside of Zoom, go click chat, and you should see it, Brian. Do you see it now? Okay, I'm assuming that means yes. Okay, okay, good. All right, so any questions for anybody? If you will, just Becca, let's hear from you. Just unmute for me and tell me how you're doing. Tell me what's going on. What can we help you with? If you have any questions. How are you doing this morning? All right, looks like you're muted.
Okay, now I'm unmuted.
Okay, how are you doing?
I am doing good. I allowed life to happen, and it has prevented me from being able to do all of the, like, both of the 2-hour videos in a day. It's
Okay,
extremely hard, especially with working and kids and life in general.
okay,
So I kind of slowed it down, but I have the days before my test to be able to slow it down and do one video a day.
okay.
So I'm glad I have that opportunity, but it's all super helpful, and I am continuing to make my drawings
Nice.
every single day.
Oh, I love it.
Um,
I love it.
I have copies and copies and copies, and figuring out the right kind of pattern for me to be able to do that.
Okay. All right. Did you have any question today? Anything that you want us to go over today?
I think endocrine is what I struggle the most on.
Okay.
But you've really helped me with understanding that. You've broken it down a couple of times, I think. It's just something that I have to work extra hard on.
Okay. So, in fact, I want to say it was last week. Um, I think I went over endocrine last week. In fact,
Mhm.
and I know for sure there's an endocrine test. In fact, let me just double check this really quickly. Let me log in. I didn't have that part pulled up, but let me double check on something about the test. Give me one moment. And have you seen the new testing platform? Have you seen all the exams in there?
No, I have not.
Okay. All right. So there are a lot of exams in there. In fact, what I'm trying to pull up is to make sure there's an endocrine, but I'm pretty sure there is. Yep. There is a paramedic endocrine test already loaded into ClassMarker. So it's, I believe that one is 50 questions on all kinds of endocrine disorders. So in that one test, it will cover diabetes, thyroid emergencies, adrenal emergencies. So we'll cover like Cushing syndrome. We'll cover Addison's disease or Addisonian crisis, thyroid storm, myxedema coma. Those are probably the most important ones to know. But we'll cover a lot of things, especially in that exam. And there's also there's an additional video that I did last week. In fact, there is a whole endocrine there. So that video last week was like 2 hours and 45 minutes. We've actually chopped it up, and specifically the endocrine part that will go up as a separate video probably today. So
Awesome.
there will be a separate video specifically on endocrine. So if you just want to review that, so you'll have a video and you'll have a test with just test questions on endocrine. I would just kind of steer you to both of those. Just in the interest of time, I'm not going to necessarily go back over that, only because I covered both of those pretty extensively in the video. And I think if you'll go through the video, that'll help you a lot.
Awesome. Thank
Okay.
you.
Like for instance, let me just ask you, if I were to ask you right now, do you remember, or what could you tell me about thyroid emergencies? What could you just say off the top?
No idea.
Okay.
I really
Okay.
struggle with
So
retaining that.
the way you want to think
Uh-huh.
about endocrine emergencies and this is for everybody, the way you want to think about endocrine things is either things are speeding up or things are slowing down. So let's say we're talking about the thyroid. So last week I talked about the hormones. Kayla, do you remember the hormones? You were there last week. What are the hormones that go up in, let's say, hyperthyroidism? Unmute for me.
Um, if I remember, I think I'm getting my terms mixed up, but is it the T3 and the
It
T4? No,
is,
that's
right. So in
okay.
hyperthyroidism, T3, T4 go up, and then what hormone goes down?
The
All right, so let's go over this quickly. So that's okay. We'll just go ahead and tackle this now. So in hyperthyroidism, all right, so the hormone that's going up is we have an increase in T3 and T4, and therefore the
Mhm.
hormone that goes down is thyroid stimulating hormone, so TSH. Okay, now, or we can have hypothyroidism, and that's where your T3, T4 are going down, and conversely, your TSH is going up. So notice that. Let's draw it out kind of how it is. So here's our brain. Okay. And in the brain, remember I said last week, we have, okay, so this first thing, you don't have to know all of this. I'm just kind of orienting you to where the structures are located in the brain. So this first structure that I just drew, okay, this is the cingulate gyrus. Then we have the corpus callosum. All right. So the corpus callosum, that's the part in the middle of the head that separates the left hemisphere from the right hemisphere. That's the matter in between that allows the signals to go from one side of the head to the other side of the head. That's called the corpus callosum. So that's what I'm highlighting right now. And then under the corpus callosum, so we have, for instance, we have the thalamus, we have the hypothalamus, and then we have the pituitary. Okay, so if this is the posterior part or the back of the head, and this is the anterior or the front of the head, the pituitary has an anterior and a posterior part. Okay, so we have an anterior and a posterior pituitary. Now here, let's highlight this. Let's put this part in green. So right here in the pituitary, that's the master gland that controls all the hormones. Well, for instance, here in the pituitary, it sends a signal to, let's say, your thyroid. And so last week I said, remember that the thyroid is sitting in front of the trachea. So let's put a thyroid in. So it's kind of this butterfly shaped gland that sits in front of the trachea. So anterior to the trachea. And so it produces something called TSH. Okay. And then it also produces T3, T4. So what happens here, in fact, let's put TSH, let's put it more being controlled by the pituitary and T3, T4 primarily with the thyroid. So what happens is when the thyroid is releasing a lot of this, it sends a signal back here to say, all right, calm down the TSH. So when we have too much of this, we don't need as much of this. Okay. But when we have a little amount of this, then we need more of this. So there's what's called negative feedback. As one goes up, the other goes down. As one goes down, the other goes up. Does that make sense? That part so far, Becca? Okay, so now let's talk about the hyperthyroid situation. In hyperthyroid, some common situations that could cause it would be things like it could be Graves' disease. So that's an autoimmune condition. You could have medications or drugs, drugs or meds that could cause your thyroid to be overactive. Now, some symptoms that you're going to have is you want to think of everything being increased. So we have an increase in heart rate, we have an increase in blood pressure, we have an increase in metabolism, we have an increase in temperature. Okay, we have an increase in GI motility. So what does all this actually mean? Okay, increased heart rate, so that's tachycardia. Increased blood pressure is probably going to cause them to be hypertensive. So they're tachycardic, they're hypertensive, they're tachypnic, their breathing rate is faster due to a higher metabolism. Also, if your metabolism is higher, you're going to be losing weight. so they're going to be skinny, so they'll have weight loss. If they have an increase in GI motility, the gut is more active, so now they're going to have things like diarrhea, increased temperature. They're probably likely to have a fever, or they have what's called heat intolerance. So everybody else is comfortable in the room, but they're hot. Okay, just think of everything being ramped up in hyperthyroid. The dangerous part of this, or the most life-threatening form of this, would be a thyroid storm. Okay, so thyroid storm. Think of a storm. It's going crazy. What you want to know here is because in a thyroid storm, you have a dangerously high heart rate. You have a dangerously high blood pressure, for instance. So this dangerously high heart rate can put you into things like VTAC. Okay, or this dangerously high blood pressure can cause you to have a stroke, can cause you to have a heart attack, can cause you to have a hypertensive crisis. So all of those are things that are life-threatening emergencies. So we've got a big treatment here. If somebody's in a thyroid storm, the way you're going to recognize it is everything is just going out of control, but especially heart rate is through the roof, blood pressure's through the roof, things like that. The biggest treatment here is going to be a beta blocker. And the drug of choice is the beta blocker known as propranolol. Okay, now if you don't have propranolol, you may not carry that in EMS. That is kind of the drug of choice for it, but if you don't have it, then another beta blocker based on what your protocols allow. Okay, so that's thyroid storm. That's where everything is ramped up. Let's talk about the opposite side of that. So now let's go over to hypothyroidism. Remember, so your T3, T4 levels are low, and therefore your TSH levels are high. In this case, all right, so in this case, some causes could be the autoimmune condition Hashimoto. So Hashimoto thyroiditis, okay? Who gets these kind of autoimmune conditions? Typically, it's going to be females greater than 40 years old. So greater than 40-year-old female, that's just kind of the prototype or the stereotypical person of who gets it. Anybody could get it, but what's an autoimmune condition? It's where your own body starts attacking itself. So in this case, your own body starts attacking your own thyroid. So it could be Hashimoto. It could be, let's say somebody has had surgery. Okay, so maybe their thyroid had to be taken out either due to a goiter. A goiter is an enlarged thyroid. Some people who get this would be people who have iodine deficiency. So iodine is in salts, or not all salts. There's iodized and non-iodized salts. So let's say somebody is on some kind of non-iodized salt. They never go out to restaurants where salt is added in the food. It's less likely that in the US somebody would have an iodine deficiency, but it could happen. But worldwide is where we see this more. But going back to the surgery, so somebody could have had some problem where maybe their thyroid was getting too big and it was starting to squeeze on their airway, and they had to take it out to keep the person alive. When you remove the thyroid, now you no longer have that thyroid hormone, and thyroid is something that we need to keep us alive. Like, for instance, we need cortisol. We also need thyroid hormone. Without it, you can't really stay alive. So somebody could have had it taken out. Now, when they've had it taken out, so whether they had a hemithyroidectomy or total thyroidectomy, they're going to be on meds for life, and they'll be on something like Synthroid, levothyroxine, okay? And they'll be on it for life. We mentioned all of this last week, by the way. Now, the dangerous form of this one, so first of all, let's talk about the symptoms. So in hyperthyroid, everything is kind of ramped up. In hypothyroid, things are kind of calmed down. So you're going to have a decrease in heart rate, a decrease in respiratory rate, a decrease in blood pressure. Instead of your metabolism being ramped up, your metabolism is going to be down. Instead of GI being up, you're going to have a decrease in GI motility. You'll have a decrease in temperature. Okay, now what does this mean practically? Decreased heart rate, so that's bradycardia. Decreased respiratory rate, bradypnea. Decreased blood pressure, hypotension. Decreased metabolism. Well, now if your metabolism is going down, that means you're packing on weight, so they're probably going to have weight gain. Decrease in GI means that stuff isn't moving through your gut, so now you're going to have constipation. Decreased temperature, you're probably going to be cold. While everybody else is comfortable, you're cold all the time. So think about a person, think about like a greater than 40-year-old female who's feeling sluggish and hypotensive and weak, gaining weight, having constipation, they're cold all the time. That's how those kind of symptoms would present. Now, just like everything, so the way I want you to think of it, everything is kind of like a continuum. So we're going to say this is low and this is high, okay? Well, let's say this part in the middle, that's where you have kind of a normal thyroid, or we call that euthyroid. Okay, so you could be euthyroid. If things go low, that's hypothyroidism. If things go high, that's hyperthyroidism. But things can go low and then they can go too low. Things can go high and then they can go too high. So if we're talking about thyroid, hypothyroidism is hypothyroidism. But the dangerously low part of that, that's going to be myxedema coma. So the dangerous part is myxedema. And I didn't actually write it this way last week, so this may help to just kind of visually see it this way. So the dangerous part of hypothyroid is myxedema. Then you have hypothyroid, then you have euthyroid. Then you have hyperthyroid, and then the dangerous part of that is going to be thyroid storm. Okay? Now, Becca, so that's thyroid. That's probably the most, that's not every single thing, but that's the most important things that you need to be able to recognize, especially in a question. Okay? That sometimes they'll give you the lab values. It's less likely that they'll give you like thyroid lab values because those aren't ones that most people are taught at this level. But they will give you symptoms. They'll describe a patient. All right, so Becca, let's go. You ready?
I'll attempt it.
Let's go. You got this. So, all right, so Becca, we have a patient with, all right, so you've got a patient that has, oh yeah, these are the exact notes from last week. All right, so you have a patient with, they've lost a lot of weight, they're running a fever, they have diarrhea, things like that. What is something that you are likely to suspect? Because if they just have increased heart rate with symptoms, that just means they're sick. But if they have increased heart rate, increased blood pressure, increased temperature, if they're sweating, what kinds of things might you think there? Well, you could think of it could be some kind of drug overdose. It could be some kind of sympathomimetic agent that's causing activation of your sympathetic nervous system. It could also be thyroid. In this case, is it likely to be hyper or hypothyroid?
Hypo.
If everything's ramped up?
Oh, no, hyper, sorry.
It's going to be hyperthyroid. In hyperthyroid, tell me about your T3, T4 compared to your TSH.
So in hyper, the T3, T4 is low and TSH is high, right?
All right, it's the opposite way. So the lab value that we're always kind of looking at is T3, T4. In hyper, T3, T4 is up. In hypo, T3, T4 is down. So the number one lab value that we're looking at is the free T3, T4 level. And then the TSH is going to have the opposite effect. So in hyper, tell me again, in hyper, which way does the T3, T4 go?
It's elevated.
Okay. Therefore, the TSH is going to be?
Low.
Low. Okay. All right. Who gets hyperthyroidism? Who are some people who have this or who are predisposed to have this?
Females over the age of 40.
Okay. Now that's for any autoimmune condition, whether we're talking, Graves' disease, myasthenia gravis, lupus, systemic lupus erythematosus, any of these autoimmune conditions. The kind of epidemiology of who gets it is primarily females greater than 40. That's for all these conditions. But other things so what kind of autoimmune condition
like
would
Hashimoto's?
Okay, Hashimoto is for hypothyroid. So let's go
Okay.
back over that.
But you have Hashimoto's over on hyper side.
So I have Hashimoto on the hypo side.
Oh, okay.
Okay, so everything over here is on the low side. Oh, okay. I see what you mean compared to this line.
Yes.
So I
I
probably
thought
should
those
flip
two
flop those.
coincide.
Okay. So
Okay.
yeah, I probably should redraw it and flip flop that for you, but I'll have you do that. On the low side, on hypothyroid, your T3, T4 are going to be low. Your TSH is going to be high. Some things that cause hypothyroidism are Hashimoto. So Hashimoto. Okay. So hypo and Hashimoto, they go together.
Okay.
If they've had their thyroid removed, now they can't make as much thyroid, or they can't make any if they've had the whole thyroid removed. So of course
Right.
their thyroid is going to be low. It may have been removed due to a goiter. It may have been removed due to maybe they had radiation before. Maybe they had lung cancer from smoking and they had to get radiation to their throat and that damaged their thyroid. That could have caused it. In hypo, everything is low. Okay?
Mm-hmm.
The dangerous form of this is what's called myxedema coma. Okay, so myxedema, I have it on the low side right here.
Mm-hmm.
It's the most severe or the most life-threatening form of a low thyroid. Let's talk about the high. In the high side, so I'm over here, in hyperthyroidism, your T3 and T4 are going to be elevated. Your TSH is going to be low. Some causes of hyperthyroidism are going to be Graves' disease, which is another autoimmune situation, just in the opposite effect.
Right.
Different drugs or medications, but everything is going to be ramped up in hyper. Because think about it, they're hyperactive, okay? The most severe form of hyperthyroidism is thyroid storm. This is where everything is dangerously high, okay? And this dangerously high heart rate can send them into a tachydysrhythmia. This dangerously high blood pressure can send them into a stroke, a heart attack, hypertensive crisis, things like that. The drug of choice to treat thyroid storm is a beta blocker. The number one beta blocker that we use, if it's available, is propranolol. Okay?
So Brian asks, is a thyroid storm the same thing as a thyroid crisis? And I'm also curious about that.
Yes. So those are just different terms for the same kind of thing. Okay? Thyroid storm, thyroid crisis, yes. That would be the same situation.
Awesome.
Okay. Now, how do you feel about that? You think you can give me that again?
Yeah, absolutely.
Okay.
It'll be something that I have to like write and redraw so that way I can pull it back up in my mind.
Okay. See what you can do just by talking to me.
So hypothyroidism is when your T3, T4 is low. Hashimoto's is one of them that go with it. It is an autoimmune disorder. So it goes with your women that are over 40 are most likely for your autoimmune disorders. So everything is low. With hyperthyroidism, that is Graves' disease, everything is elevated, your heart rate, your blood pressure, putting you at risk for stroke and other heart-related issues. And it is when your T3, T4 is elevated and your TSH is low.
Okay. Okay. All right. So here, let's do it this way. We can let's just redraw it and we're going to do it right now. So as your thyroid starts to go low, okay, so now you're in the hypo, okay? And then when it gets dangerously low,
it's myxedema coma.
So really low. All right, so let's just call that hypo, and then we'll call the other one really low, okay? So what's the dangerously low thyroid called again?
Myxedema coma.
Okay, so that's going to be myxedema coma. Think about it. When you're in a coma, Everything's low, right? You're
Right.
kind of like passed out. Okay. Then you have hypothyroidism. Now, hypothyroidism, tell me again. So give me some situations for hypothyroid.
Hashimoto's.
Okay. So it could be caused by Hashimoto. That's an autoimmune condition. Okay.
Right.
What else could cause it? What else could make your thyroid not work as well?
If they've had surgery.
Okay. So when it comes to surgery, you could either have part of it taken out or all of it taken out. So that's going to be, let's say if you have half of it taken out, that's a hemithyroidectomy. Hemi meaning half. Thyroid is thyroid. Ectomy meaning to remove. So when you remove half of it, that's a hemithyroidectomy. Or if you remove all of it, that's a total thyroidectomy. So that's surgery. Okay, cool. What else? What else could make it underactive? Okay, it could be that you have a goiter. So a goiter is where it's enlarged, but because it's enlarged, it's affecting the function of it. Okay, so it's not working normally.
Right.
So a goiter can go either way with it being hypo or hyper. A goiter can cause both. Another cause would be an iodine deficiency. All right, let's tie something in. If somebody is allergic to iodine, what antidysrhythmic should they not have?
Oh, is it lidocaine?
It's not lidocaine.
No, it's amiodarone.
It's amiodarone, okay? Because in amiodarone, let's watch this. Amiodarone. So,
right.
So amiodarone has kind of this IOD in it.
Hmm?
Okay. So
that's what I'm trying to think of.
Okay, right. So in amiodarone, that's where we would probably, if they have an iodine allergy, we would not give them amiodarone. Okay.
Right.
Okay. So those, now tell me about your lab values in hypo. T3, T4 are going to be?
I don't remember what you said the lab values were.
Okay. I mean, but is it going to be up or down for hypo?
Oh, it's up for hypo.
So in hypo, you have a decreased T3, T4, and increased TSH.
Mm-hmm.
Okay. What kind of symptoms are they going to have? If it's hypo, that means low. So everything is low. Everything like what?
So they'll have elevated weight or weight gain.
Okay. So I don't want you to say it as elevated, only because I want you to think of everything being low. So we're going to say it a different way. So let's start with heart rate, decreased heart rate. So we would call that bradycardia. Okay. Decreased blood pressure, we would call that what? Hypotension. Okay. Decreased respiratory rate, we would call that?
Bradypnea.
Okay, cool. Bradypnea.
Is that how you say that?
It is. That is. Bradypnea, yes. Okay. Decrease GI motility, we would call that constipation.
Okay.
And then decrease metabolism. That's how I want you to say it. Decrease metabolism. And that's going to be weight gain. Weight gain. Okay? Does that make sense?
Yes.
Then you can have what's called a normal thyroid. And the word for that is euthyroid. Okay? Now let's go to the high side. So as things start getting higher, so now we have hyperthyroidism. Okay? In hyperthyroid, how are our T3, T4 going to be?
It's elevated.
So we're going to have elevated T3, T4. We're going to have a decreased what?
TSH.
Okay, TSH stands for thyroid stimulating hormone.
Okay.
Okay, so decreased thyroid stimulating hormone. Now, in this situation, because it's hyper, everything is elevated.
Right.
Okay.
So elevated heart rate, meaning tachycardia.
All right. So they're going to be tachycardic. Okay. So elevated blood pressure
Blood
or
pressure
elevated,
is
elevated BP,
hypertension,
hypertension. Okay. Elevated respiratory rate,
tachypnea,
tachypnea. Okay. Elevated GI motility.
which could be diarrhea
That's going to
or
probably lead to diarrhea. Okay. Elevated metabolism.
which is weight loss.
That's going to be weight loss. Elevated temperature. Fever.
Yes.
Okay. Or they're febrile. And on the other side, I should put,
So if hypo, wouldn't they also be just cold?
yes. So in hypo, they have a decreased temperature. So they have what's called cold intolerance. Okay. Does it help to kind of visualize it like this?
It absolutely does. Which you said previously that our minds pull up pictures and not words, which mine absolutely does. So to
Everybody's
visually
does.
it's something I can recall later on when I'm sitting and I'm like, oh crap, what was that? Okay, let's picture what he drew out. Now let's make those lists going down.
Okay. Now, but I'm not having to just memorize bullet points. What I'm having to think about is, okay, it's either normal, it's low, or it's dangerously low. It's normal, it's high, or it's dangerously high. Okay. Now let's talk about the hyperthyroid where everything is high. What causes that? What are some causes of hyperthyroid? Say it again.
Graves' disease.
Graves' disease. That's another autoimmune condition. So notice that both of these, so Hashimoto and Graves, they're both autoimmune conditions. They're just on different sides of the coin. Okay.
Right.
All right. What else could cause it? Well,
medication.
Say it again. Okay. Certain
Drugs,
medications or certain, let's say, illicit drugs. Okay. What else? And these are big ones to know. Now, you could also have a goiter here, but especially what's called a toxic goiter or toxic multinodular goiter. Okay, what is that? So if this is the thyroid gland, okay, the thyroid should just be kind of a smooth surface. However, in a goiter, it gets bigger. So let's make the thyroid bigger. So let's okay, a goiter is where the thyroid is now bigger. That's just a goiter. However, when you have nodules in it, that's called a nodular goiter. Okay? But if these nodules are now, like the nodules may just be sitting there, not causing any problems, it's just a nodular goiter. However, if these nodules are actually causing the thyroid to secrete too much thyroid, then we call it toxic. So then it's a toxic goiter, okay? So in hyperthyroid, a toxic goiter could be the cause. Now, let's go to the worst case of this. And this is where it's dangerously high. Where it's dangerously high. And what do we call that situation?
I don't remember.
That's going to be your thyroid storm.
Oh, yeah.
Okay. So now, instead of it just being elevated heart rate or tachyarrhythmia, it's like dangerously high heart rate, dangerously high blood pressure. So just think about it. Everything is being dangerously high. So we're on the danger side. Okay. What's our big treatment here?
To lower everything.
Okay. So think about it. What could I do to lower, what could I give to lower heart rate? What could I give to lower blood pressure?
Beta blockers?
Yeah, what could I do to do both of those? That would be a beta blocker. So I'm not having to memorize it. I just say, okay, it's too high. What could I give? What do I have in my toolbox that can lower heart rate, that can lower blood pressure? Okay, so for both of those, that's going to be a beta blocker. And what's the number one beta blocker?
Propranolol.
Propranolol. Propranolol. Okay. Now, does that make sense?
Yes.
That's thyroid. Okay. Now, we could do this exact same kind of thing for, let's say, adrenal emergencies. But in the interest of time, what I want you to do is I want you to go back to the video where I covered it,
Mhm.
because I talked about Cushing's, I talked about Addison's disease. I actually drew out the adrenal gland. I talked about the different hormones that get made in the different parts in the adrenal medulla versus the adrenal cortex. Who was here last week that remembers this? Does anybody remember from last week? What hormones, or what is the middle section of the adrenal called? So you've got the outside and then you have the inside. What is the inside of the adrenal gland called? Type that in the chat for me. Okay. All right. So that's going to be anybody know? Okay. So that's going to be the adrenal medulla. And then the outside, that's going to be the adrenal cortex. Now, I did do a whole video on this last week. So just go back to it. In fact, let's see if I have, yeah, because these are the notes from last week. So, oh, you're not seeing what I'm doing. So yeah, this is what I drew last week. So go back over this. I also uploaded this exact document with my notes. That's uploaded under last week's video. Now let's review something really quickly though. So I was just asking Becca, I said, okay, how could we lower heart rate? So let's review this. This would be a good topic because this kind of gets into some medications. So let's just add a page here. All right. So when it comes to, let's say, heart rate, well, first of all, I want you to know the number one equation for perfusion. And the number one equation for perfusion is blood pressure. And this is, everybody pay attention here because this is really, really, really important. In fact, don't even worry about taking notes of this part because I'll just upload this document again for you. But this one equation tells us so much information if you just understand the equation. And this equation for blood pressure is heart rate times stroke volume times systemic vascular resistance. Okay? Now, here's what I want you to see. So when any of these things go up, it also causes blood pressure to go up. When these things go down, it also causes blood pressure to go down. Now watch, this is like magic if you get it. Okay? Now watch this. So what could I do to, let's say heart rate is high. What could I do to lower the heart rate? Well, for heart rate, we said for heart rate, there are three ways that we lower heart rate. And they come down to our A, B, C. A, that's going to be adenosine. B is beta blocker. C is calcium channel blocker. Okay? Those are three ways that we lower heart rate. So we either use on the medication side. Now, of course, on the electricity side, what would that be? On the electricity, so this is meds. And then when it comes to electricity, how would we lower heart rate? Type it in the chat. How would we lower heart rate with electricity? What's that called? So that's going to be our synchronized cardioversion. Okay? That's how we can lower heart rate. Now, on the other side, let's say if we need to raise the heart rate, how could we do it? Well, with meds, the one med that we give is adenosine. Okay? We can give adenosine as a medication to speed up heart. Wait a minute, that's not right. No, that's not what I meant to say. You guys don't have me saying wrong stuff. What should I have put? Because adenosine, I already said, adenosine is what we lower it with. But what is the medication that also starts with an A that we use to speed up the heart rate? Okay, that's going to be atropine. Okay, so when heart rate is low and we need to speed it up, we're going to use atropine. Okay, other medications that we can do would be epi. So Brian said epi. How does that work? Because in our epi has three main effects. And what are the three main effects of epi? Type it in the chat. Three main effects of epi. We have alpha 1, we have beta 1, we have beta 2. What does the alpha 1 effect do? Alpha 1 causes vasoconstriction. So what that does is it squeezes the blood vessel. Now, where does that work though? So this is the way I want you to think of it. Everything has to work one of these four places. So the alpha 1 effect of epi actually works on vasoconstriction, which is a resistance problem. So that actually works right here. So what that does is it increases the resistance. So epi, if I want to increase the resistance, I can use epi. Okay, that's the alpha 1 effect. But what's the beta 1 effect? The beta 1, remember you have one heart. So the beta 1 effect, what it does is it increases heart rate and it increases cardiac output. Cardiac output, okay? So this increase in heart rate part, that's going to work right here on heart rate. So epi increases heart rate, okay? Now what's the beta 2 part of epi? Remember you have two lungs. So epi works on the smooth muscle surrounding the lungs. So this is the smooth muscle part. Epi works on the smooth muscle surrounding the lungs, and it causes let's put that in blue. It causes bronchodilation. Okay, so that doesn't work on this part, but that actually works on the lungs. Now, let's talk about what could I do to improve the stroke volume? So to increase the stroke volume, what could I do? If I want them to have more volume, what could I do? Oh, well, I could give them volume. So that's going to be fluids. Okay, so to increase stroke volume, I actually give them volume. But what could I do to decrease? What could I do to decrease the stroke volume? To decrease the volume, well, I could decrease preload, because preload is the amount of volume that I load up previously. Okay, so now how could I do that? What kind of med decreases preload? That's going to be nitroglycerin or any of the nitrates. Okay, what else could I do to drop volume? Well, I could cause bleeding, or not that we want to cause bleeding, but anything that causes bleeding or volume loss. How could we lose volume? Well, we could lose volume through like bleeding. That's hemorrhagic shock. We could also lose volume through vomiting. We could lose volume through diarrhea. Okay, so let's say vomiting. Let's say diarrhea. Now, notice what I'm doing here. All I'm doing is I literally started with a blank sheet and I'm coming up with this on the fly. I'm not having to memorize PowerPoints. I'm just going to think, and we're just going to think together on the fly. So vomiting, for instance, what kind of acid-base problem is that going to cause? Type it in the chat. Vomiting is going to cause what acid-base disturbance? Everybody with me? All right, so vomiting, that causes metabolic alkalosis. Diarrhea causes metabolic acidosis. Okay, those are ways that you can lose volume. Now, let's talk about resistance. How could I, if resistance is low, blood pressure is going to be, if resistance is low, that means that, oh, I'm sorry, no. If resistance goes low, then blood pressure goes low. If resistance goes high, then blood pressure goes high. Okay, what are some things that could cause you to have a low resistance? Low resistance means, another way to think of that is you've got a lot of space. Resistance is like, are things able to flow freely? If you have a lot of space in the pipes, resistance goes down because you got bigger space. So let's do it this way. Let's draw it out. So low resistance is where you have big pipes. High resistance is where you have skinny pipes, okay? So the low resistance, that's going to be vasodilation. What are some things that cause vasodilation? Oh, there again, we have nitrates. So nitroglycerin. So notice that nitro causes vasodilation. Nitro causes venodilation. Okay. What else dilates your blood vessels? Oh, things like calcium channel blockers. Calcium channel blockers. Now, what else? Let's go to the opposite side. What could cause vasoconstriction? Well, we already said things like epi could do it. What else could cause vasoconstriction? Norepi, epi, norepi. So anything that causes the blood vessels to kind of clamp down. I want you to just kind of this, I'm telling you, if you will know this, there's so much that we could come up with from this one equation. Like I promise you, I could actually sit here for another hour and we could just go on and on and on about this. But now let's talk about the blood pressure side. Okay. So what are things that we do? Let's say blood pressure is high and we need to lower blood pressure. What are the ways that we do, or what are the types of medications that we give to lower blood pressure? So to lower the blood pressure, we're going to do our A, B, C, D. Wait, hold on. I did that wrong because we got a lot of like ABCs. So it's A, B, C, D. Okay. So these are our antihypertensives that lower blood pressure. So what are they? That's going to be number one, we have, or you tell me. Somebody tell me, what are some ways that we can lower blood pressure? What are some classes that we can use? Type it in the chat. Type it in the chat for me. All right, everybody with me? Okay, so let's go. We're going to have ACE inhibitors. Okay, so adenosine is not so much used for blood pressure. Adenosine, Brian, is more used for heart rate. Okay, notice how I have adenosine as one of the ABC for heart rate. But for blood pressure, our three A's are primarily going to be ACE inhibitors. So those are going to be the prils. Okay, we have our ARBs. Those are our angiotensin II receptor blockers. These are our sartans. Okay, good. Nice, Kayla. All right, and then what's the other A? Okay, the other A is going to be alpha 1. So let's do alpha 1 antagonists. These are going to be like our zosins, prazosin, things like that. Our zosins, those are our alpha 1 antagonists. Because remember how alpha 1 causes vasoconstriction. That squeezes the blood vessel. I don't want that. I need the blood vessel to get bigger, so I'm going to use an alpha 1 antagonist. Alpha 1 agonist causes vasoconstriction, so an alpha 1 antagonist causes vasodilation. Okay, and how does that work? If I do vasodilation, that's going to also drop the blood pressure. Okay, so alpha 1 antagonist, the B for blood pressure, that's going to be a beta blocker. The C is going to be calcium channel blocker. Remember, our calcium channel blockers come in two flavors. We have the, nice, Kayla, check you out. So we have the dihydropyridines and the non-dihydropyridines. So we have either the di, so the di or the non-di. Okay, the di, that's going to be the dihydropyridines. And those are the ones that end in pene or dipene, amlodipine, nifedipine, nicardipine. Okay, those are your dihydropyridine calcium channel blockers that dilate. So we have dilate. Okay, so these also cause vasodilation. Okay, so we have the drugs like amlodipine. It's a dipene that dilates, and it's a dihydropyridine. Okay? And it causes vasodilation. So that's going to decrease systemic vascular resistance. In turn, that decreases blood pressure. Okay. And then the non-dihydropyridines, these are going to be drugs like, so these, instead of working on blood vessels, they work on the heart muscle. And some examples of those are going to be diltiazem, also known as cardizem, and verapamil. Okay. Now, this is a review. I've covered all of this in the cohorts. It's also in the comprehensive study guide. It's in the Coach Joshua's 5-star drawing study guide. But for everybody, this would hopefully be a good review. And then when it comes to D, the D's for blood pressure, this is primarily going to be diuretics. Okay. And we have different diuretics that work in different parts of the kidney. So we have loop diuretics. These are your simides, like furosemide, so Lasix. Okay, those are your simides. We also have thiazide diuretics. That's going to be things like hydrochlorothiazide. Okay. We also have potassium-sparing diuretics. Okay, your potassium-sparing diuretics, these are going to be your SEAT drugs. That's going to be spironolactone. That's going to be eplerenone. That's going to be amiloride and triamterene. Okay? All right. I'm telling you, this is like, look, notice how much we covered. What I would want you to do is I want you to, everybody with me for a second? What I want you to do is I want you to recreate this on your own. So let's go back over this. What I did is I started off with just one equation, that blood pressure is heart rate times stroke volume times systemic vascular resistance. Okay. Then I said that if heart rate goes up, it causes blood pressure to eventually go up. Stroke volume going up eventually causes blood pressure to go up. Systemic vascular resistance going up eventually causes blood pressure to go up. So if any of these three, or all of these three, or two of the three, if they go up, blood pressure goes up. On the other hand, if these things go down, blood pressure goes down. Okay. Now, all we have to do is we figure out, okay, so if the heart rate is high, what can I do to bring it down? What can I do to lower heart rate? To lower heart rate, I can use adenosine, beta blockers, calcium channel blockers. What else could I do? So those are on the medication side. To lower heart rate with electricity, I can go to synchronized cardioversion. Now, what if heart rate is low and I need to speed it up? Well, on the medication side, I can go with atropine. I can go with epi. Let's also put norepi. So Levophed. On the electricity side, to speed up the heart rate, I'm going to do transcutaneous pacing. Okay? Now, I'm not having to memorize anything. I can just think right now on the fly. Let's say stroke volume is high and I need to bring it down. Well, what are some things that cause stroke volume to go down? Well, if I have a decrease in preload, what can do that? Things like nitroglycerin or any of the nitrates. What else can cause us to lose volume? Things like vomiting. Vomiting is going to lead to things like metabolic alkalosis. We could also lose fluid through diarrhea. Diarrhea is going to lead to metabolic acidosis. Okay? What if the volume is low and I need to give them more volume? How can I give more volume? Well, the main thing that we have there is fluids. Okay? Now, when it comes to fluids, it's either going to be a isotonic crystalloid, a hypotonic crystalloid, or a hypertonic crystalloid. Those are crystalloids. But we have crystalloids and then we have colloids. Okay? Now, what's some examples of isotonic crystalloids? That's going to be normal saline, lactated ringers. What's some examples of hypotonic crystalloids? Hypotonic crystalloids, hypo. So the way I remember this is hypo-hippo. So like a hippo is big and swollen. When I give a hypotonic crystalloid, it causes the cells to swell. What's some examples of this? That's going to be things like half normal saline, things like that, or just pure water. This is why we never just give somebody pure water in an IV. There's always salt mixed in with it. If I give straight water in their IV, I cause the cells to swell. This is why also, let's use this little concept here. How else can I apply this? This is why some people have a test question. They say, okay, somebody has a knocked out tooth. What kind of solution would you put the tooth in? And they say, okay, like put it in milk. The reason we don't put the tooth in just sterile water, that it would make sense to just use sterile water, right? Because we have a bottle of sterile water on the ambulance. But why do we not put the tooth in sterile water? Because sterile water is pure water that's just been sterilized, but it doesn't have electrolytes in it. So if I put that tooth in water, just water by itself, even if it is sterile water, that just means it doesn't have bacteria. But what it's going to do is it's actually going to cause the cells to swell and die. So we're going to damage the nerve of the tooth. That's why we don't put it in sterile water. That's why we put it in something like milk. I don't want you memorizing that. I want you, that just comes straight from physiology of a cell. Okay. What are some examples of hypertonic crystalloids? That's going to be things like, let's say D5, 3% normal saline, things like that. Okay. That's how we can give fluids, or we give fluids to improve stroke volume. Now, when it comes to resistance, if the resistance is already high, remember, if resistance is high, blood pressure is going to be high. So what can I do to lower the resistance? Well, I need to cause vasodilation. How could I do that? I can give nitro, or if I give nitro, it's going to do this. Another thing is going to be your PDE5 inhibitors. That's going to be your fields, sildenafil, tadalafil, vardenafil. So that's going to be our Viagra, Levitra, Cialis, things like that. How else can I cause vasodilation? Oh yeah, calcium channel blockers can do it. Okay. Calcium channel blockers, we also said alpha-1 antagonists can do it. All right. Now, what if the resistance is already too low and I need to increase the resistance? I need to cause more squeeze on the blood vessel. How can I do that? That's going to be meds like epi, norepi. Okay. But look how many meds we just covered from this. I just started with one equation, and look how many meds we've already gotten to. These happen to be some of the most commonly tested meds because they're also the most commonly prescribed meds. Okay. And I said, for blood pressure, what are meds that lower blood pressure? That's going to be our, how do we say it, Kayla? Kayla, come off mute for me. Hit me one good time, Kayla. How do we do it?
A, B, C, D.
Nice. I love it. A, B, C, D. Nice. Okay. So the A, that's going to be ACE inhibitors. Those are going to be our prils. The ARBs, that's angiotensin 2 receptor blockers. Those are our sartans. The Zosins, those are our alpha-1 antagonists. Beta blockers, those are our LAWs. Okay. C, that's going to be calcium channel blockers. They come in two forms. Remember, we have dihydropyridines that dilate blood vessels. All right, so these are going to dilate, they dilate blood vessels. And they end in dipene, so amlodipine, nifedipine, nicardipine, okay? Or we have non-dihydropyridines. They work on the heart muscle itself. Examples of those are diltiazem, also known as cardizem, or verapamil. Now, when it comes to the D drugs that lower blood pressure, that's going to be diuretics. Our examples there, we have loop diuretics. Those are your simides, furosemide, budesonide. Those are your simides. Those are loop diuretics. Now, all of these work on different electrolytes. You don't have to know that part. Just kind of know loop diuretics, your simides. These specifically work on sodium chloride. And they're called this because of where they work. They call, like, loop diuretics are called loop diuretics. Here, let's draw this out. Okay, there's your proximal convoluted tubule. Then we have your loop. We have your thin part. then you have your thick part, then you get to your distal convoluted tubule. Let's make that squiggly. Your distal convoluted tubule, then you have your collecting duct. Okay? Your loop diuretics work here. They work in the loop. Your thiazide diuretics work here in the distal convoluted tubule, and then your potassium sparing diuretics work here in the collecting duct. Okay? So your loop diuretics like furosemide work right here. Your thiazide diuretics like hydrochlorothiazide work right here in the distal convoluted tubule. And then your potassium sparing drugs, your seat drugs, they're going to work over here in your collecting duct. So we have spironolactone over here, eplerenone, amelioride, triamterene. All right. I promise you guys, this is for those of you who struggle with pharm, this, like what we just did, these are probably some of the most important drugs to know. All right. Any questions on that? I know that was a lot. So today we went back over thyroid stuff, and then I directed you to the video from last week. We also covered a whole lot of medications from this one equation. What I want you to do is I want you to recreate this. So go back and watch over this video. It should go up later today. Go back and watch this video. Be able to recreate all of this for thyroid. Create your own list like this for adrenal situations. Okay? And then I want you to definitely take this equation. Blood pressure is heart rate times stroke volume times systemic vascular resistance. And I want you to recreate this whole situation that we came up with. Any questions? I didn't even know we were going to go to that, but that's where we ended up. Any questions? All right, we lost Becca. Monica, how you doing? Monica, you still there? All right, if you guys can
I'm
turn
here.
on.
I'm here. I was on capstone, so I'm muted.
Okay, so did you learn something today?
I came in at the end because I was on an MVA, but I learned a lot based on what I saw so far, and I'll be rewatching it once it's uploaded.
Definitely rewatch this one because we covered a lot today. And for everybody, for those of you who came on later, so Billy, Monica, for those of you who came on later, let's see, Billy just said, okay, no problem. But for those of you who came on later, something that is critical is I dropped a link here. Let me just drop this link again in the chat. I'm going to do it right now. There's a link for this form. What I want you to do is go ahead and click on it right now so that it'll open it up before we close the session. This form is for everybody who hasn't tested yet, which is all of you. I want every single person to fill out this form because it'll give us information on like when is your test date, what are you struggling with, things like that. At the beginning of this discussion today, I started off with that we posted a whole lot of questions in class marker. Every single person that has not passed their test. So I think like 111 of you, we gave you access to class marker. Everybody should have access to class marker. You have multiple exams already loaded. You have multiple diagnostic exams. You have multiple specific content exams. Check your email. You should get an email from class marker with all your login access. Yes, Monica. So if you already have access, then fine. Just make sure you remember your username and your password, or save it. Just save it as a favorite or whatever. Bookmark the tab. But the other thing is I want you to go back and check in it because just since yesterday, there are more tests that have been added that have all the tests were already there. We just made them available yesterday. So now you have access to them. Now, there are even more tests than what you see, but those are primarily the final exams. And so we did not make all of them available because some of you have a tendency to just go ahead and do them all. And so we wanted to keep some of them just kind of held back. Hold on. No, Monica, so even if you did complete a form before, I still want everybody to complete this form because it gives us the most up-to-date information and it allows all the information to go in one place. So instead of me having to go back through all those chat messages, everything will go into one form for us now.
Okay. One quick question I have about the test is some of them said it said like 0 of 2 tries. You only get, is that how each one had like a different amount of tries that you could have on the test? Is that normal?
Yes. So for the diagnostic type exams or the specific subject content exams, for those you can do them twice, but for the final exams, you can only do those once, and those are timed. So we have timed and untimed. The timed ones are the final exams. You get one attempt at those. And so I need you to treat it like it's the real exam because you only get that one attempt and it's timed. The rest of them are untimed. Did that answer that question? Monica, did that answer that? Okay, I'm assuming yes. Okay,
yes,
Brian,
it did. Thank you.
Okay, cool. No problem. Brian says, can I go over when do you do synchronized cardioversion and the amount of electricity? Okay, so this is going to come from your ACLS standards. And there was a question last week, and I didn't get to answer this last week, but this was one of the questions that got submitted. So let's answer it for everybody. There was a question on, does National Registry use the 2020 guidelines or the 2025 guidelines? So if you go to National Registry's website, they've put the guidelines for 2025. We're now in the second half of 2026. So it's very likely that, I mean, you definitely want to know 2025 guidelines because those are the most current guidelines. But it's less likely that you're going to have a question where it's like some nitpicky detail of something that came from 2020 or something that comes from 2025. What you want to know, though, is the general information that hasn't really changed, like rate of compressions, depth of compressions, things like that. That's going to be the same for both 2020 and 2025. So you really want to just know your basic stuff. Also, in terms of like the first line medications that we use, that hasn't really changed. So what I would say is know your 2025 guidelines and know your general stuff for cardiac arrest management. The 4 types of cardiac arrest or 4 subtypes. We have VFib, pulseless VTAC, PEA, asystole. What drug does every single cardiac arrest get? Epi. What are the 3 priorities in cardiac arrest? High quality CPR, early defibrillation, early IV IO access for epi. That hasn't changed in years. Okay, so you want to know those kinds of things. That's where most of your questions will come from. So whoever answered that or whoever asked that question, hopefully I just answered that. Now, Brian's question was on, okay, so let's talk about electricity. So, and there again, it comes from what we just talked about. Blood pressure is heart rate times stroke volume times systemic vascular resistance, right? Okay. When it comes to electricity, and remember all of this, so what else do you know? Let's tie something else in. Remember, everything comes down to we either improve oxygenation, ventilation, or perfusion. Okay? This equation, notice how I have it all in red. This equation is the perfusion equation. So when it comes to heart rate, if we need to improve heart rate, so let's say this. Let's do it this way. So let's say we're talking about heart rate, and we're going to use electricity. Okay? So if the heart rate is slow, so if they have bradycardia, producing symptoms. Now, of course, this is for unstable. Well, hold on. Let's do it this way. Okay? So your heart rate can either be slow, so we'd call that bradycardia, or your heart rate can be fast. So we call that tachycardia, right? All right, this is just basic stuff. Everybody knows this. Okay, but it comes down to if it's stable or unstable. So we have stable, and then we have unstable. All right. Okay. And of course, we're talking about it's producing symptoms. So there's a problem with your heart rate and it's producing symptoms. So we're going to call that symptomatic It's either symptomatic bradycardia or it's symptomatic tachycardia. Okay. Now, the reason I stress that is because just because your heart rate is slow doesn't mean we do anything about it. We only do something if it's causing symptoms. So, thus, symptomatic bradycardia. Just because your heart rate is fast, like if you run outside right now, your heart rate is fast, but I don't chase you down and say, come here, let me cardiovert you. No, because you're not having symptoms. So, it's symptomatic tachycardia, symptomatic bradycardia. Okay. Now, the question is, if they have symptomatic bradycardia and they're stable, what do I do? Now, what's stable? Well, first of all, what is stable versus unstable? Unstable is where they have, for instance, I want you to think of CASH. They have CASH symptoms. That's going to be chest pain, altered mental status, shortness of breath, so dyspnea, or hypotension. Okay? If they have, for instance, a low heart rate and they have these symptoms, then we're going to use electricity. But if they have a low heart rate without these symptoms, we're going to say they're stable and we're just going to go with meds. So what medication do I use for symptomatic stable bradycardia? Okay, type it in the chat. Symptomatic stable bradycardia. Remember earlier we were talking about how can I improve heart rate with meds? How can I improve heart rate? That's going to be here. That's going to be our atropine, epi, norepi. So, but our first line drug is going to be atropine. Let's do. So if they have a slow heart rate, we'll use atropine. That's going to be our first line drug. What else could we use? We could also use epi. Okay. But atropine first. Now, let's say they have symptomatic unstable bradycardia. Then what are we going to do? We're going to go with electricity, and that's going to be in the form of pacing. Okay? And if you'll go to the comprehensive study guide, for those of you at the pro level, there's a whole section, just do a search for pacing. There's actually a step-by-step where I walk you through how to do pacing. Same for synchronized cardioversion. Now, let's talk about symptomatic stable tachycardia. So they have tachycardia, but it's stable, so it's not causing all these kind of symptoms. In this case, we're going to go with medications to lower heart rate. In that case, what's the drug that we use primarily to lower heart rate? It's right here. That's going to be adenosine, beta blocker, calcium channel blocker. So that would be adenosine. Now, how does the adenosine work? We give our first 6 milligrams rapid IV push with a flush. Okay? If that doesn't, well, that's not the first thing we do. The first thing we do is a vagal maneuver. Okay? The vagal maneuver activates the baroreceptor reflex and calms down the heart rate. If you go to the comprehensive study guide, if you go to Coach Joshua's drawing study guide, I actually draw out the whole mechanism of a baroreceptor reflex. So the very first thing we do is get them to vagal down. That could be by getting them to bear down like they're trying to poop. We could take a straw, pinch it, and then have them blow through it like that. No matter what, or you could take, let's say it's a kid, you could take their face and like dunk it in some ice and water if you're at their house, or you can take an ice pack and put it on their face. All of those things, what they do is they actually cause you to close your glottis. They close the glottic opening, activating the vagus nerve, and then it slows down the heart rate. If that doesn't work, we go with our first dose of adenosine. Remember that we're going to use at least an 18-gauge catheter in the left AC. We're going to use a 3-way stopcock. We're going to flush it with a 20 ml flush, and we have to do all of this in 3 to 5 seconds because of the short half-life. So you always want to have a partner whenever you're using a 3-way stopcock. The paramedic, you're going to push the adenosine and flip the lever, and then you're going to have your partner push the flush. Don't try to do this by yourself, and don't try to do it any other way. This is the correct way to push adenosine. If that doesn't work, then we're going to go with our second dose of adenosine, and that's going to be our 12 milligram rapid IV push with a flush. And when I say flush, I mean like a 20 ml flush. And then if that doesn't work, we've done our first 2 doses of adenosine. If that doesn't work, now we're down here and we're going to go to synchronized cardioversion. Okay. Now, the question was, how do I do synchronized cardioversion? Well, the question was, how much electricity? What kind of comes down to, is this a narrow complex or is this a wide complex? Okay, so a narrow complex, that's going to be something like, that either will be maybe SVT, it could be really high sinus tach, SVT, PSVT, but it's a narrow complex. Now, a wide complex tachycardia, that could be something like VTach with a pulse. So in narrow complex, we probably will start with like 50 joules. There again, just go based on your protocols and AHA guidelines for ACLS. But we would probably start, now this is for an adult. Of course, it's going to be different for kids. And you want to know adult versus peds. Okay? But we would start with like 50 joules, and then we're just going to keep ramping it up. Okay? But we'll either go 50 to 100 joules for most narrow complex. For most wide complex, we'll either go, we may have to go with like 120 joules of biphasic. Okay, now for peds, in fact, let me show you something. Oh, in my little handy dandy flip chart here. Somebody tell me, what is the dose for peds? We probably should do a whole separate thing on just ACLS. I mean, it's in the study guide, and I've covered it in some of the cohorts, but probably we could do another session where I just go through that. 0.01 or 0.1, wait a minute, 0.1 milligram per kilogram for what? Billy? You sure about that? Okay, so let me stop for just a second. When it comes to your drugs for cardiac arrest or ACLS, the drugs you want to know are epi, atropine, adenosine, amiodarone, lidocaine, mag. Okay, these are like your big drugs that you want to know when it comes to ACLS and PALS. And of course, these are different versus adult versus peds. And what I would like to do, only because we're over our hour, we're almost an hour and a half now, and I could actually do a whole session on this. Because this is very important, not just for the test, but this is actually really important in real life every day. And what I'd like to do is draw all of this out, but I need a little more time than I have. Like I need a little more time than the 7 minutes I have to fully explain this. So why don't we table this part until, this could actually be Thursday. Okay, this could be Thursday, and then what I can do is I can draw all of this out for you. Would everybody be okay with that? I mean, I know the answer, it's just, I don't want to just give you the answer. I want you to know how I'm coming up with all of this. Would everybody be okay with that? Because I need a little more time than 7 minutes to explain ACLS. Because there's a lot, like this is like really important stuff to know. And like I said, this is not just for your test, because out of all of this stuff, you may get 4 questions on your test out of all of this. But in real life, you need to know this every day, and you need to know this cold, especially pediatric dosages. So why don't we go over that Thursday? That would be a great topic. Now, the question is, can we do it at 8 a.m. on Thursday? Probably not. So what I did is there's a morning session for the week, and then there's an evening session. So Tuesdays, it's in the mornings, and Thursdays, it's in the evenings. There is a Wednesday morning session tomorrow where we're starting off with our first accountability calls. So we could perhaps cover it tomorrow, but if not, we'll do it Thursday evening. And if you miss it, everything gets recorded, and so you'll just catch it in the replay. Any other questions? We covered a lot today, but any other questions that anybody has right off? Kayla? All right, we're gonna stop in 6 minutes for sure because we're over.
Well, it's fine. One of them was kind of already answered briefly. Like one of them was I struggle a lot with the terminology. Like some of the words I can understand, like the cardi and the hyper, those things.
Okay. What does cardi mean?
Heart.
Okay. And hypo means?
Low.
Hyper means?
High.
It doesn't sound like you're struggling.
Well, like when it comes to, combining them with things like with, what's the naming for decrease in heart rate? It's like it takes me a while, and so I can't like get it right off the bat. And then when it comes to like questions like, okay, so you're getting these signs and symptoms. So what would it be? Is it bradycardia, tachycardia? Is it dyspnea? Yeah. So it's just kind of those things that I get tripped up on.
Okay, so let's go over this quickly. So when it comes to words, when it comes to naming conventions for words, right? You have the main word itself, so that's going to be called the root word. Okay?
Mm-hmm.
Now all words have to have a root. Okay?
Yes.
They may or may not have a prefix or suffix. The word in the front, that's going to be our prefix, and the word in the back, that's going to be our suffix. Okay? So some common prefixes. All right. So one of them you mentioned, that's going to be Brady. Brady means?
Don't tell me I know it.
Look at the screen.
Slow.
Okay. So what's the word for fast?
Tacky.
Tacky. Okay. What's the word for normal? You. We talked about euthyroid today. That's a normal thyroid. Okay.
Gotcha.
Euvolemia is normal volume. Hypovolemia. Oh, so hypo is low.
Mm-hmm.
Hyper is high or excessive. Okay. Dis means difficult. Okay.
Mm-hmm.
Let's go over like suffixes. Let's say algia means pain. Okay. Like fibromyalgia or dentalgia, so dental pain. Okay. Now, itis, inflammation, or some kind of swelling of. Okay. Ology, study of. Okay. So let's say we have pathology, that's study of disease. Physiology, study of the function. Okay. Let's say we talked about an ectomy. That's a removal of. So like if we're a surgical removal of, we said a hemithyroidectomy or partial or a total thyroidectomy. That's an ectomy. Okay. What about a osis? That's an abnormal condition of. Okay. Pulmonary fibrosis, anthracosis, sarcoidosis, pneumoconiosis, bacilliosis, right? The osis, those are abnormal conditions of. Okay. Those are just common ones to know. Now, let's go over root words. Okay. Cardi is what? Heart. Let's go hepato. What's that? Okay. Hepatitis is inflammation of the. What's that?
Liver.
Okay. Let's go spleno. What's that?
Your spleen.
Spleen. Okay. Now let's do another suffix like megaly. if somebody has splenomegaly, what's that? That's an enlargement of the spleen. Splenomegaly. Hepatomegaly. If they have hepatomegaly, what's that?
Enlargement of the liver.
Enlargement of the liver. Okay, that could come from Crohn's disease. I meant to say cirrhosis. It could come from cirrhosis. It could come from alcoholic liver, fatty liver, things like that. Okay. Oh, what if they have? This is a good one. Emia. So emia is something in the blood. So if they have, hyperkalemia, that's elevated what in the blood? Elevated potassium. What if they have hyperglycemia? What's that? Elevated what in the blood?
Sugars.
Sugar. What if they have hypoglycemia?
That's low blood sugar.
That's low blood sugar. Okay. What if they have hyponatremia? That's going to be low sodium. Okay. So when it comes to lab values, we have the K is for potassium. The Na is for sodium. The glyce is for blood sugar. Okay. Let's say somebody has, not cyto. Let's just say penia. If somebody has some kind of penia, that's where they have a low amount of. So if they have thrombocyto, so cyto means cell. Thrombo means platelet. So if they have thrombocytopenia, that means they have a low platelet count. However, if they have thrombocytosis, that means they have a high platelet count. If they have neutropenia, that means they have a low amount of neutrophils, which are a type of white blood cell.
Mm-hmm.
Okay. So these are very common ones to know. And for this, what I would recommend is just flashcards and just kind of repeat them over and over and over. Or if you'll go back, like you could literally just Google or go to ChatGPT or Claude or whatever AI tool you use and ask for 100 of the most common medical terms.
Okay.
Top 100 medical terms. Okay. And then ask for, what you want to know is these words are made up of prefixes, root words, and suffixes. And then the way we join these things together is typically with like the letter O, and that's going to be what's called a combining form. Okay, so O is kind of the letter that's in the middle of how we take this word and stick it together. We typically put an O in the middle. Not always, but that's the most common combining form. All right, so I'm over now on time. But this is something, I'm glad you asked this though, because even though it's very basic, it's something that trips up a lot of paramedics also because they just simply don't know the word. And so much of medicine comes down to just knowing the vocabulary. But when you know the vocabulary well, everything is so much easier. Okay? Like tension typically is some kind of pressure.
Mm-hmm.
So like blood pressure. So if we have hypotension, that's low blood pressure. Hypertension, high blood pressure. Okay? But just think about how many things we came up with today. So just from this, we talked about tachycardia, bradycardia, hypotension, hypertension. We talked about vasoconstriction, vasodilation. Let's put those in. So we have, so that would be more of a suffix, constriction, dilation. Constriction means to get smaller or to squeeze.
Yes.
Dilation is to get bigger or to relax. Okay, we have vaso, we have veno. Vaso typically comes with arterioles. Veno is for veins. All right, and just think about how many words, like a lot of this came up just today. And what you notice is I'm just using these terms, but I've been using these terms for 20 something, like 25 years. So this is just like my second language. It's going to be the same for you. The more you use these terms, the easier it becomes. Okay, this is just like I just speak the language of medicine. And the more you use it, though, or the more you hear it, the better it's going to come. It's going to become just second nature. All right. Right now, you're just kind of in the beginning of you're kind of early in the game. But once you've been in the game for a while, you'll just rattle off these terms. Okay.
Okay.
But definitely go back over this. This is a great list to have. If you want, you can just take a screenshot of that.
Definitely.
You got it?
Not yet.
Okay. Tell me when.
I got it.
You got it. Okay. Now, any other questions? Because we're over on time.
I mean, the other question I have is it's a big question, so I'm sure I can find it in some of the other videos.
Just go ahead. Ask it.
It just has to I'm trying to how I can better understand like the respiratory stuff with I know you gave the acronyms, the CCED, like for croupy cough, and then the epiglottitis.
Okay.
Drooling,
So look,
and
hold on.
stuff.
So you're talking about primarily pediatric respiratory conditions, and I use CC'd, like you CC'd somebody on your email, and that is croup or croupy cough. So the seal-like barking cough is for croup. And then with epiglottitis, we have drooling, okay? Also known as salivation. Now, but what's your question?
Is like where, so I'm trying, because I like the pictures and stuff. I'm just trying to like remember, like, because a lot of the questions ask you like, okay, is it like when, for example, like, okay, they have a seal-like bark. Okay, so is it going to be a upper or lower respiratory? And so it's just trying to
So
figure
we're
that
going to
out.
call this a seal-like barking cough. That's a way, basically, when they use seal-like bark or barking cough, seal-like barking cough, they're pointing to croup. What is croup? So croup is, the official name for croup is laryngo, tracheo, bronchio, litis. Okay, let's break that down. Itis means?
Inflammation.
Okay, so we got swelling. Swelling of what? Swelling of the boom, boom, boom. What are those things? Okay, so let's do our airway. So we got to start with just knowing basic airway anatomy. So of course we've got a mouth, we've got a nose. So let's call that a mouth and a nose. So air comes into the mouth or the nose, right? And then it goes through, it gets into so this part here, that's going to be called we have what's called the pharynx. And by the way, it's pharynx. Wait, pharynx. It's not pharynx. Okay, don't pronounce it pharynx. It's pharynx, larynx. Okay, so you want to pronounce it like rinks, R-A-N-K-S, like a skating rink. Okay, so pharynx and larynx. Now the larynx, that's your voice box. Okay, but then it branches off into, now we're going to get into the trachea, and the trachea has these rings, these cartilaginous rings. Then we get into our lower airways. And now, so these big ones here, those are called the, one of them is called a bronchus. If we're talking, so we have a left bronchus, and then we have a right bronchus. But if we're talking both of them, the plural is called bronchi.
Mm-hmm.
Okay, bronchi is plural. But then we get into the smaller airways where it branches off even more, and these are called bronchioles. Okay, so when it comes to the respiratory, and then eventually we get down to the alveoli. Okay, alveoli. So this, you just have to know your anatomy for everything. But so we've got a nose, we've got a mouth, we've got the oral pharynx, and then a little lower. So we've got an oral pharynx, we have a nasal pharynx, and then they come together at the pharynx, and then the lower part of that is called the hypopharynx. Hypo meaning low or underactive. So underneath the pharynx is the hypopharynx. Then we have our larynx. That's the entrance to that's the voice box. That's the entrance to the trachea. The trachea, we recognize it by these cartilaginous rings. This bifurcation or this split where it branches off into the left side versus the right side, that split is the carina. Okay, the carina happens to be at the level of about, so this is the carina. It happens to be at the level of T4. That's just a good thing to know. So it's about the thoracic, the fourth thoracic vertebrae is about the level of the carina at the level of T4. So croup. Croup is inflammation of the larynx, trachea, and bronchioles. Not bronchi, but bronchioles. So we have the larynx, trachea, bronchioles. That's croup. Well, of course, the bronchi is in between. But if we have inflammation of all this stuff, that's croup. Okay?
Gotcha.
So croup, this stuff gets all the way down to, especially when we're at the bronchiole level, we're down to the lower airways. So that's primarily going to be a lower airway obstruction. Okay? But now what is croup? It's primarily due to a viral infection. And viral infections are gradual onset versus slow onset.
Mm-hmm.
Okay? Now, let's talk about epiglottitis. So an epiglottitis, so let's break it down. Epiglottitis, inflammation of the
epiglottis.
Epiglottis. Where's the epiglottis? Well, the epiglottis is, okay, so we have the larynx, and then, so we have the trachea, okay, and then, like, there are actually two tubes. So let's do it side by side. I'm going to put trachea in blue because that's going to the lungs, and then sitting right behind that, we have the esophagus. So this is our trachea, and then behind the trachea, we have the esophagus. Okay. Mm-hmm. Of course, the trachea ends up going into the lungs. The esophagus goes into the what?
Your stomach.
Goes into the stomach. This is why we have to be careful that we don't put too much air in somebody when we're breathing for them, because we can actually cause air to end up going down the esophagus into the stomach. We make the stomach bigger, bigger, bigger. Now we, but because it's inside of skin and all of that, it starts getting bigger, 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 pressing on the inferior vena cava, and now you stop blood coming back to the heart. Now, let's go back to where we were, though. So we have the trachea and we have the esophagus. Well, there's this little flap right here. There's this little flap that closes. Well, it doesn't close like that. It closes. There's this little flap that covers the trachea, like when you swallow. so that the food goes down the esophagus and not down the trachea. That little flap is what's called the epiglottis. So notice where it is. The epiglottis is pretty high up. So that's going to be like up here in the upper airway. Okay. So epiglottitis is primarily going to be in more of an upper airway situation versus croup affects down in the lower airways. But I'm not memorizing it. I just come up with a picture and then I just know the picture. Okay. So epiglottitis primarily affects what part of the airway? Upper or lower?
Upper.
Okay. Primarily affects the upper airway, where we have an inflammation of the little flap that covers the trachea. Okay. What causes it? So if croup is primarily caused by a viral infection, and the virus is going to be parainfluenza virus, primarily. It could also be RSV, respiratory syncytial virus. All right, now let's talk about epiglottitis. It's primarily caused by a bacterial infection. Bacterial infections, because bacteria divide so quickly, like you take something like E. coli, it can divide in about 20 minutes. Like you got double the amount in just 20 minutes. So bacterial infections spread quickly. So it's going to be more of a sudden onset instead of slow onset. So it happens quickly. This is why it's so life-threatening, because all those bacteria, like you start off with 2. 20 minutes later, you got 4. 20 minutes after that, you got 8. And then it just quickly divides. Okay. The most common bacteria is Haemophilus influenza type B. It could also be strep. You don't have to know this part. It could also be strep, like streptococcus. It could also be staph, like staphylococcus. Okay, but those are all bacteria. Okay, Haemophilus, streptococcus, staphylococcus. Those are all bacteria that cause a sudden onset. Now, if we have swelling of the airway, or any swelling can cause the airway to narrow. Okay, if we have narrowing of the upper airways, what's that called? What's it called?
Okay, stridor.
Stridor. Okay, and you must know this. Narrowing of the upper airway is stridor. Okay, narrowing somewhere down in the lower airway, what's that called?
Is that wheezing?
It is.
Okay.
Okay, so wheezing is narrowing of the lower airway. Stridor is narrowing of the upper airway. You got me going way over time. That's okay.
No, I said it was a big
That's all right. That's fine. So now, but stridor can be due to not just epiglottitis. It can be anything that causes an airway. Let's say we have a burn. They inhale gases that burn their upper airway. That can cause stridor. They have an allergic reaction that gets really severe called anaphylaxis. That can cause stridor. Stridor is just a sound. Wheezing is just a sound. Yeah, so wheezing can be caused by asthma. Wheezing can be caused by COPD exacerbation. Wheezing you can have cardiac wheezing with pulmonary edema. Those are just sounds. You want to know stridor is the sound due to a narrowing of the upper airway for lots of reasons. Wheezing is a sound due to narrowing of the lower airway for lots of reasons. When do you typically hear stridor? Stridor is typically heard on inhalation. So when you inhale, so it's called inspiratory stridor. Wheezing, on the other hand, can be due to inhalation or exhalation. So you can have inspiratory or expiratory stridor. Wait a minute. What am I writing here? That's supposed to be inhale. Okay. This is definitely basic stuff to know, though. So you really want to master this. Did that answer that question?
It did. Thank you.
Okay. So I want you to, here, let's go. You ready? All right, Kayla, it's me and you. It's us against the world. Let's go. Okay. So I want you to picture the airway, right? So how do we breathe? When we first breathe in, air goes through we got two ways to get it in normally, unless there's a hole in the neck. And by the way, what would that hole in the neck be called?
Oh, I know it's not coming on the top of my head.
Okay, that hole in the neck, that's going to be a stoma.
Stoma. There we go.
Okay.
Let me start with an S.
So that hole in the neck is going to be a stoma, S-T-O-M-A. But typically, most people don't have a hole in their neck. So most people get air either through their nose or their mouth. Okay. So inhale through their, oh, by the way, let's go over respirations, because this is a big thing. When I breathe in, so I'm either going to breathe in or I'm going to breathe out. Those are my options, right? Now, when I breathe in, what makes me breathe in? What makes you take your next breath right now?
With the excess of CO2.
Ooh, okay. I like it. Okay. All right. So the excess of CO2, what would I call that, by the way? If I'm talking about medical terminology, what would I call an excess CO2?
Is that with our ventilation or not ventilation?
Okay. So excess is hyper. And when we're talking about CO2, sometimes it'll be referred to as carby or capne. So if they have hypercapnia, so it's either hypercarbia or hypercapnia. That's excess CO2. So this is CO2, this is CO2. Hypercapnia, hypercarbia. Those are excess CO2. So typically for normal healthy lungs, it's an excess CO2 that causes you to breathe. Now, where in your body is it figuring out you got too much CO2? Where's the sensor for that?
Is it in your alveoli or the capillaries?
You know where I'm drawing right now?
Oh, in your brain.
Okay, so this part, all right, so this right here is the brain. This right here is the brain stem. And the brain stem is what feeds into the what? Spinal cord.
Mm-hmm.
Okay, so you definitely got a lot to review. Okay, not putting you on the spot, but it's not just you, it's most people. Okay, so we got so let's go over this very top part. So this is the brain, right? And then we have, so that's what we would call the cerebrum. Then we got this part at the back here that's involved in muscle coordination. What's that called?
Cerebellum.
That's your cerebellum. It's involved in movement and muscle coordination. Then we have the brain stem. Now, this first part right here of the brain stem, that's called the midbrain. Then this next part here is called the pons. And then this last part is called the medulla oblongata. Okay. In the medulla oblongata, that's where your respiratory center is located. So that's the part that detects, oh, we got too much CO2. Or for people who have COPD, it detects that we have not enough oxygen. So the two triggers to breathe are either too much CO2 or too little oxygen. Okay? So they're located here, and they're also located in the aortic arch. So the aortic arch, that's going to be, so here's your heart. And as blood leaves this left ventricle, it goes through a valve, the aortic valve, and then it goes into this aorta. And then there's an arch.
Mm-hmm.
And there are these branches off the arch. But inside the arch, that's where these other chemoreceptors are. Okay, so you have them in the carotid sinus. Okay, and then they're there, and they're also in the carotid sinus, which is here. So here. Okay, so these things detect that you have too much CO2 or not enough oxygen, and then they cause you to breathe. Now, when you breathe, what happens? So air now rushes into either your nose or your mouth, and it goes in. And you keep breathing in until when? Like, what makes you stop breathing in? When do you stop breathing in? All right, so this is the way I want you to think of it. So you have your lungs.
Mm-hmm.
And then let's just call that lungs. Okay. So you've got the outside world. And okay, this is the outside world. And this is the inside world.
Mm-hmm.
What makes the air go in is when first the pressure is higher on the outside and it's low on the inside.
Mm.
So when this pressure is higher, air goes from high to low, or pressure goes from high to low. So that's what makes you breathe in. But you keep breathing in until the pressures are equal.
Mm-hmm.
And now once the pressure inside and the pressure outside are equal, so I should have done it this way. When this pressure is high and this pressure is low, air goes in. You keep
Gotcha.
breathing in until the pressures are equal.
Right.
And
Okay.
then once the pressure on the inside is high and the pressure on the outside is low, which way does the air go? It always goes from
Out.
high to low.
Mm-hmm.
So which way does it go then?
Out.
Out. That's what makes you breathe out. So what makes you breathe in is pressure that's high from the outside. What makes you breathe out is pressure that's high on the inside.
Mm-hmm.
So that's what's called a pressure gradient. A gradient just means it's different. If the pressures are the same, there's no gradient. Gradient means one side is high, one side is low. Does that make sense?
Yes.
So repeat that. First of all, tell me what's the trigger that makes us breathe, and then what actually causes the air to rush in or rush out.
Okay. What causes us to breathe is we have too much CO2.
Okay, and where does that get detected? Give me two places.
Up in the don't tell me. I just have to think about it real quick. In the brainstem.
Okay.
Through
What part of the
the
brainstem?
It's called the medulla
Medulla oblongata.
oblongata.
Okay.
Yep.
In the medulla oblongata, say it again. The what?
Medulla oblongata.
Yeah, that's right. The movie Waterboy. That's right. Okay. So in the medulla oblongata. And where else are these are called chemoreceptors. Where else are these chemoreceptors located?
In the it travels down through the spinal cord, and then isn't it in that little aorta arch?
Okay, so the aortic arch, and I
Mhm.
misspoke. This is called a baroreceptor in the carotid sinus. It's actually a chemoreceptor in what's called the carotid body. But it's in the carotid, it's in the neck. But
Right.
it's in the carotid body, not carotid sinus. I
Okay.
misspoke there.
Okay.
Carotid sinus is for baroreceptors. Carotid body
Okay.
is for chemoreceptors. Okay, anyway, so it's in the heart and it's in the brainstem. Those are where your big chemoreceptors are located. Now, so that actually causes let's talk about the physiology of respirations. So what makes the air go in again?
Is this that part now where it's the pressure is
Yep.
high on the outside? Okay.
That's right. So the atmospheric pressure is high. The
Mhm.
pressure inside the chest is low. So
Oh.
this is called atmospheric pressure. This is called intrathoracic pressure. Okay. What makes you breathe in is when the atmospheric pressure is high and the
Mhm.
intrathoracic pressure is low. Now air goes in. And it keeps going in until what happens? When is the thing that makes it say, all right, no more air in?
When the inside pressure is it higher, or is it when it's level? Or
It's
when
level.
it's
So when they're level, there's no high side, there's no low side, so there's no movement of air. Air only moves when one side is higher than the other.
Mhm.
Okay?
Okay.
So when both let's do them as like boxes. So when this pressure and this pressure are equal, does air move? Yes or no?
No.
No. But when this side is bigger, which way does the air move?
In.
Okay. When this side is bigger, which way does the air move?
Out.
Okay, got it. All right, you got that part. Now, what's actually making the air, like what allows the air to go in or not? So I need another page. See, I didn't know we were going here, but I'm always ready. Okay, so all right, so here's your lungs, right? Let's just put some lungs in there. And boom, let's call that lungs. Then there's this big muscle that separates the chest from the abdomen. What's that big muscle called?
Your diaphragm.
This is the diaphragm, okay? The position that I just drew it in, that's the diaphragm at rest. All right, so this is the diaphragm at rest versus when you inhale. Okay, hold on. Let's do it this way. When you inhale, the diaphragm goes to this position. Okay, so the diaphragm actually moves down. So we call that constricts or contract. So, and that happens during inhalation. Now, because this muscle had to constrict, the muscle had to do some work. So that's called active. So inhalation is active. On the other hand, when you exhale, the diaphragm goes back up to this normal position, but it just does it. Like it doesn't have to work to relax. It just happens. So this is where the diaphragm relaxes. Think about it. When you are working versus when you're just chilling. When you're chilling, you're not working, right? So this is during exhalation, and this is called passive. So exhalation is typically passive. Inhalation is working under normal conditions. However, if you're in distress, so if you're in respiratory distress, let's put that in blue. So if you're in respiratory distress, which is what kind of problem? Is it oxygenation, ventilation, or perfusion?
Oxygenation.
Okay, it's an oxygenation problem. Okay, now you've got like an increased heart rate, an increased respiratory rate. So now if you're struggling to breathe, of course, those options can be mild respiratory distress, moderate respiratory distress, severe respiratory distress. Now, let's say you're struggling to breathe. So then what happens is now you're having to use other muscles to help you breathe in. Now, where do you have other muscles that come in and start doing some work? What other muscles can I pull on to help me breathe?
Your neck muscles.
Okay.
Your abdominal muscles.
So these muscles in the neck, what are they called?
It's not coming to my head right now.
Okay. I just drew it. I just wrote it. What is it? Scalenes. Okay. So we have the scalenes. We also have these other ones that are on the sides, on both sides. You know what this stands for?
No.
Okay. It's sternocleidomastoid. Let's break all that down. Sterno. What body part sounds like sterno?
Sternum.
Sternum. Okay. Cleido, that means clavicle. Mastoid, your mastoid bones are over here. So these muscles in the neck are the muscles that activate the muscles near the mastoid, the collarbone, and your sternum. So the muscle that kind of sits between all of that, that's called the sternocleidomastoid. Okay. So we have the scalenes, the sternocleidomastoid, and then we also have other muscles that get used are our abdominal muscles. Okay? You should not normally have to use these to breathe, but this is why if you see somebody and they're using all these accessory muscles, like muscles in their neck are moving when they breathe, or their belly is moving when they breathe, these are signs of respiratory distress or severe respiratory, moderate or severe respiratory distress. Does that make sense?
Yes.
Okay. Okay, so, all right, here, you tell me this back. I want you to teach this back to me. Teach me about inhalation, exhalation, what makes you breathe in terms of the pressure difference, whether it's active or passive. Let's go. And I'm going to leave the picture up for you.
Okay. All right. Well, when we inhale, it's an active part of breathing. And so the diaphragm gets constricted. And then when we have respiratory distress, then that can cause someone to use their neck muscles or their abdominal muscles, and that it becomes an oxygenation problem.
Okay.
And
that oxygenation problem can be called mild respiratory distress, moderate respiratory distress, or severe respiratory distress. Now, what if they're in mild respiratory distress? Okay, they're struggling to breathe. What kind of oxygen delivery device could I use for mild respiratory distress?
could you use a nasal cannula?
A nasal cannula. How are we going to flow it?
1 to 6.
1 to 6 liters per minute. What if it's a capnography nasal cannula?
1 to 5.
Check you out. Okay, that's going to be 1 to 5. Now, what if they're in moderate respiratory distress? What kind of airway delivery device would I use?
Would we use a non-rebreather?
Non-rebreather. I'm going to flow it how?
I want to say 10 to 15, but
just say 12. 10 would work, but I say 12 to 15 liters per minute. Okay.
Okay.
Because if they're really struggling, I'm probably going to just start them with 12. Okay. 12 to 15 liters per minute. What if I'm going to use a nebulizer?
6 to 8.
6 to 8 liters per minute. Okay. Let's say they're in severe respiratory distress. What's our oxygen delivery device probably going to be?
Okay, it is a CPAP. See, I was getting confused. I was like, gosh, is the CPAP for the ventilation? Because I know the BVM is for the ventilation, but I was getting that.
So you want to think
of
ventilation problem is where I have to help them out.
Yes.
Okay. CPAP, they got to do the work themselves. They got to breathe on their own. Okay. Ventilation is where they're not able to do it on their own. They're getting too tired, or they're just not breathing at all. They have respiratory arrest. And then that's where I'm going to help them out. But CPAP, they've got to be able to follow commands. They can't have any contraindication, but they still got to be able to do the work themselves because they have to actually suck the air in. Okay. Right. Even though the machine is working, but they still have to breathe on their own. All right. Okay. Okay. Now tell me, what's the trigger that makes them breathe in the first place? Let's go back to that.
Is this the part where we're talking about like with the 2 places where?
Okay. So what are the 2 triggers? What's the normal trigger? And then what if you have like unhealthy lungs or diseased lungs? What's the trigger for normal, healthy lungs?
Well, is this the one we're talking about, the medulla oblongata?
It is. Well, that's a structure. That's where it's happening. But first of all, what is the trigger? So it's either triggering that we have too much of something or too little of something.
Yeah, where we have too much CO2.
Okay, in normal, healthy lungs, it's too much CO2. But if they have like COPD, it's too little oxygen.
Right.
Those are the 2 triggers. The triggers are either too much carbon dioxide for normal people. And when I say normal people, I mean normal lungs. Or if they have problems with their lungs, their trigger is too little oxygen. Those are the options. Okay. Both of these situations are detected by the chemoreceptors in the medulla oblongata and the aortic arch and the carotid body. Okay. Those are called, what are these things called that detect CO2 or O2? What are they called? Because these things are chemicals. So what are the
Mhm.
receptors that detect chemicals?
Oh,
Chemo receptors.
okay, chemoreceptors.
Okay. You have chemoreceptors and then you have baroreceptors. Baro means pressure. So baroreceptors either detect high or low blood pressure.
Gotcha.
Okay.
Okay.
Chemoreceptors detect either high CO2 or low oxygen. Okay. You got that again? Give me that back.
Yeah.
Teach that back to me.
Okay. So chemoreceptors detect high CO2 and low O2.
Okay.
And
Where are those
then
chemoreceptors located?
in the medulla oblongata,
Medulla oblongata. What else?
and then the aortic arch.
Aortic arch
Aortic
and the
arch. Oh,
carotid
carotid
body.
body.
Carotid body. You have a carotid sinus, carotid body. Both of them are in the carotids. They're close to each other. They're just called different things. Okay, that's cool. Now, when your chemoreceptors say, "Ooh, they got too much CO2, we need to make them breathe," air goes in as long as. Tell me about the pressure part.
Air goes in as long as there's lower pressure inside.
Okay,
And
so
so
that's called a lower. What kind of pressure? It's either what's this pressure on the outside called? That's out there in the environment, in the
yeah,
atmosphere.
atmospheric.
So that's called atmospheric pressure.
Yep, atmospheric pressure.
And then the pressure inside the chest cavity is called the
hypo something. Hypo.
no, that's called
Oh.
it's within the thorax.
Okay.
So the word for within is intra.
Oh, okay.
So
Intrathoracic.
intrathoracic.
Okay.
Okay. Oh, these are good suffixes to know. Hold on, let's add that to the list. So, or these are prefixes. So, inter, intra, inter means between, intra means within. So, within the thorax is intrathoracic. Within the abdomen is intra-abdominal. Within the brain is intracerebral. Okay. All right. Now, if the atmospheric pressure is high and the intrathoracic pressure is low, air moves which way?
In.
In. And when you breathe in, is that called inhalation or exhalation?
Inhalation.
Is that going to be active or passive?
Active.
Okay. And what's the main muscle that should get used during inhalation only? What's the muscle that should be used?
Your diaphragm.
Okay. And which way does the diaphragm move when you inhale?
Down.
It moves down. We call that constriction or contraction. Okay. Now, that's in normal situations. Now, when you normally breathe in, how much air do you move?
When you breathe in?
Yep. So our normal breathing in or breathing out, what is the amount of air that we normally breathe in or normally breathe out? And I keep stressing normally because this is when we're just like sitting here right now. How much air gets normally moved in or out?
Are you like asking to like percentage wise or
Volume wise?
Volume.
So it's about 500 milliliters of air, and that is called your what is the volume of air that normally gets moved in or out? What's that called? That's called tidal volume.
Right.
So our normal tidal volume, a normal tide, what goes in, so you know how the tide in the ocean, it goes in and out. So our normal tide is about 500 milliliters of air. Okay. This is why when you're having to ventilate somebody with a bag valve mask, because that bag valve mask, here's your bag, and then here's your little tube, and here's your mask, right? Your bag valve mask, how much air does that hold? It holds about 1,500 milliliters of air. So if you squeeze all of that air out of the bag one full time with one hand or two hands, you're putting way too much air in their lungs, because their lungs normally only hold about 500 milliliters of air, and they don't even use all of that. They only use about 350 milliliters, because some of it is just kind of hanging out in this dead space.
Right.
Okay. So if you squeeze this whole bag, you're giving them way too much. This is why you want to gently squeeze the bag with about 2 fingers. Well, 3 fingers, like your thumb and 2 fingers. That's about all the air they get, just enough to make the chest rise, because otherwise you're giving them way more than their normal tidal volume. Okay. That's normal breathing. Now, what if we take a really deep breath in because we're struggling? Now we're going to have to use different accessory muscles, such as
our scalenes in the neck, and then the sternocleidomastoid.
So put it all together, and you have the
SCM.
But if you, so what is SCM?
Sorry, sternocleidomastoid.
Yeah, the SCM is sternocleidomastoid. So we have the scalenes, we have the sternocleidomastoids, and then we also have the abdominal. Oh, and then the ones between the ribs, those are the intercostals.
Oh yeah, there is those ones too. Yeah.
Okay, inter meaning between rib, costal is rib, between ribs is intercostals. Okay, those are the accessory muscles. Tell me the accessory muscles that we have to use, especially when we can't get air in, when we have an oxygenation problem like respiratory distress.
So list all the ones. Okay.
Let's go.
So we have the sternocleidomastoid.
Sternocleidomastoid. What else?
The scalenes.
Scalenes. What else?
The intercostal muscles.
Intercostal, and then intra-abdominal. And then these intra-abdominal, they are called the external and internal. Okay, but we're just going to call it intra-abdominal muscles. Okay, now when you take a deep breath in, this is what happens. So let's say so what I just drew here, this is normal ventilation. But let me show you what happens if you take a real deep breath in. It looks like this. Instead of a normal tidal volume, when it goes up, that's inhalation. It's a really deep breath in like that. That's a deep inhalation. So this is what's called the inspiratory reserve volume. Okay? Or if we take and we do a really deep breath out, that's called the expiratory reserve volume.
Okay.
Okay. Did you learn this part?
Yes, I learned it through one of your videos.
Okay, but what about in school?
I did learn it in school. It's just they when they did it, it was very fast, so it was more of like me reading it in the book.
Okay.
And all that.
And then so these are some. So what is the normal amount of air that gets moved? What is this volume called? Or this one right here? What's that volume called?
Tidal volume.
Tidal volume. When you take a deep breath in, what's that called? Inspiratory reserve volume. When you go and really blow it out, what's that called? Expiratory reserve volume. And then there's also a little air that's kind of let's move this line. Okay. There's a little air. Let's do my line here. There's a little air that's left over down here, and that's called residual volume. Okay? So the main 4 volumes you want to know in the lungs, we have what's called a tidal volume, an inspiratory reserve volume, that's where you take a really deep breath in. Expiratory reserve volume, that's where you take a really deep breath out. And then the part that's still left, there's always a little bit left over way down in the alveoli, and that's going to be what's called your residual volume. That's the part that keeps the alveoli open so that it's kind of like a balloon. You don't want that balloon to slam completely shut because it's going to take so much effort to make your next breath. So there's a little air that stays in there to make it easier to breathe. That little air that's left over that you never get rid of, hopefully, that's called your residual volume. Now, when I add up all these volumes, when I add up tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus residual volume, when I add up all of those, this whole thing is called total lung capacity. Okay?
Right.
Those are
Okay.
like the volumes to know. So I gave you 5. What's total lung capacity?
It's where you add up your tidal volume, your inspiratory, expiratory, and your residual volume.
Okay. Yep. That's total lung capacity. What's tidal volume? This
It's
part right
your
here.
the normal normal breathing.
Yeah, it's about the normal amount that you breathe in and out with a normal breath when you're at rest. How much air should normally move in or out with your tidal volume?
500 milliliters.
About 500 milliliters. Why should you not squeeze the whole bag?
Because you'll give them more than what they need.
Okay, and if I give them more than what they need, what happens? I take air instead of pushing it in the trachea. Where does this excess air go?
Does it go into the stomach?
It goes down the esophagus into the stomach. I make the pressure inside the stomach bigger, 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 bigger. What do I press on?
Your superior vena cava.
Well, it's the one coming from the bottom, so that's the
inferior
vena cava. Okay, cool. Notice how much stuff we tied in this one picture?
Yeah.
So here's what I want you to do. I want you to redraw this yourself. I want you to so here's what I want you to do.
Okay.
I want you to take a blank sheet of paper or a dry erase board or whatever. And I want you to do exactly what I did today.
Okay.
All right. So Johnny, we're about done. We're like way over time. But Kayla just wanted to hang out extra with me. So what I'm going to have you do, Johnny, is go back over the replay because we covered a lot today. So we covered thyroid, like hyperthyroid, hypothyroid, myxedema coma, thyroid storm. We went over blood pressure medications. Now we're going over airway stuff. We've also gone over medical terminology. So there's been a lot in today's video. All right. But Kayla, what I want you to do is go back over, take a blank sheet of paper or dry erase board, whatever. Just take a blank screen or whatever you have. And I want you to go back through exactly what we did. Okay. Draw out an airway, starting with the nose and the mouth, then going into the nasopharynx or the oral pharynx, those converging in the pharynx. Below the pharynx, we have the hypopharynx. Then we have the larynx. Okay. We talked about epiglottitis. We talked about croup. Draw out the whole airway from after we go through the larynx, then we go to the trachea, then we go to we have the left. Well, first it splits at the carina. What's the level of the carina? What vertebrae does it correlate to?
T4.
Okay, about the level of T4. Okay, then we split into the left main stem bronchus, the right main stem bronchus. If we have two of we don't call them bronchuses, we call them bronchi. So if we have the left bronchi, the right, or if we're talking both, we're say bronchi. Then it gets down into the bronchioles. Then it gets down into the alveoli. We talked about croup being what kind of infection?
Viral.
Viral. Does it happen quickly or slowly?
Slowly.
Gradual onset. What's the number one virus?
Oh, I can't remember that one. I can't remember the
Parainfluenza virus.
one.
What's the other virus? Respiratory syncytial virus. Okay. What's the name of croup?
The laryngo. Tracheo. Bronchiolitis.
Laryngotracheobronchiolitis. Say it again.
Oh, oh gosh, laryngotrachea bronchiolitis.
Say it again, one more time.
Laryngotrachea,
Laryngo,
okay,
uh-huh,
trachea
tracheo,
bronchiolitis. Tracheo, that's right, all the O's.
uh-huh,
Bronchiolitis.
bronchio, or bronchiolitis. Laryngotracheobronchiolitis. Say it again.
Laryngotrachea
Check
bronchiolitis.
you out. Okay. Laryngotracheobronchiolitis, and that's going to produce a seal-like barking cough. So we say that we have CC'd, so croupy cough with a seal-like barking cough. All right. Tell me about epiglottitis.
Epiglottitis is more of drooling, and it's a bacterial, and
Okay.
so it's sudden. And it's in the upper airway.
Okay.
And then 3 causes for is
3 main bacteria. So Hib,
bacteria.
that's going to be Haemophilus influenza. So Haemophilus influenza type B. Strep. So that's the infection that causes strep infection. So that's a bacterial in the throat. Staph. So Staphylococcus aureus, Streptococcus pneumoniae. So, okay. We also covered inhalation versus exhalation. We went over stridor versus wheezing. Okay. We talked about not putting too much air in the lungs. Then we talked about your triggers to breathe, your hypercapnia or hypoxia. Okay. Those things we talked about. Chemoreceptors, where they're located. Chemoreceptors are located in the medulla oblongata of the brainstem. They're also located in the aortic arch and the carotid body. We talked about baroreceptors. Those are the receptors that detect pressure changes. Those are also in the brainstem, the aortic arch, but they're in the carotid sinus instead of the carotid body. We talked about normal breathing, the physiology of respiration. What makes you breathe in is when you have a high pressure on the outside, a low pressure on the inside, air goes in. And then what makes you stop breathing in or out is when the pressures on the outside and the inside are equal. And then once the pressure on the inside is big or high and the pressure on the outside is low, that is what causes air to go out. We talked about inhalation being active, where the diaphragm constricts and it goes from this position down to this position. Okay. We talked about during exhalation, this diaphragm just kind of relaxes and it goes back into this dome shape. And that's exhalation is passive. We also talked about your normal volumes. So we have a tidal volume, we have an inspiratory reserve volume, we have an expiratory reserve volume, and a residual volume. When I add them all up together, that equals total lung capacity. I want you, so here's what I want you to do. You ready? Will you promise me you'll do this?
Yes.
Say, Coach, I promise.
Coach, I promise.
Okay, I want you to take a blank sheet of paper, but don't just do it. The only way I'm going to know you do it is I need you to record a video of you doing it. And I want you to teach it back and be as detailed as possible without notes. Okay. If you need to go back, and I'm telling you, these pictures will help you come up with a lot of information because you can just use the picture to come up with everything. So I want you to record yourself giving about a 10-minute talk on everything you can think of with respirations and upload it in the community tonight.
Okay.
Or this evening. You got it?
Okay.
Now we're announcing it to the world. Kayla is going to. Okay. So I expect to see this today inside the community. And we'll all celebrate with you, but this is going to help you become so much smarter. I promise you. Just do it.
Okay.
Can I count on you?
Yes, I can do that.
And it's going to help you.
Yes.
All right. Anything else? Since you decided to take a whole hour just by yourself. No, that's fine. That's fine. I do accept Cash App, Venmo, and I'm hungry. Lunch sounds great. Uber Eats, DoorDash. No, you're good. Anything else?
Not for me. I know Johnny had a question.
Okay, Johnny, what's your question, my man? Is Johnny still on with us? Yeah. Hey,
Yes,
Johnny,
sir.
let's put Johnny in. All
Hey,
right. So, Kayla, let's get rid of you. You're too much. No, good job. I appreciate you for hanging in there with me. And was that helpful?
Yes, that was very helpful. I appreciate it.
Okay.
Yeah.
Now, don't go spreading this stuff around. We'll have 100 more students. No, actually do that. All right. So, Johnny, let's put you in so I can see you.
oh,
Because
hello.
I've got to go. I got to eat.
Oh, shoot, I'm
we're
sorry.
going to blame this on Kayla. But hey, Johnny, how you doing, man?
Yes, sir. I'm good.
All right. What's your question?
Oh yeah. I have my an NREMT tomorrow, so I just like wanted to ask like how should I like I guess like
Okay. Your NRMT exam is tomorrow. What attempt is this for you?
My fourth attempt.
Okay. All right. In this case, it would actually be good for you to do a private session with me. I don't know if you're able to do that or not. But we do have to charge for those only because there's so much demand for those. That's something that we can discuss. But in the meantime, what I would do, so that you don't have to pay any more money and it'll actually help you, is go into Class Marker. Did you get access to that? Everybody should have access to it.
Where do I go?
Because we put like
Let me see real quick.
111 people we enrolled yesterday. So you should have gotten an email from Class Marker.
Oh yeah.
And
Yes,
it'll
sir, I
have your
did.
login
I saw that.
information. And when you go into Class Marker, there's here, let me just share my screen real quick. Okay, so there's several EMT exams.
Mhm.
There's a EMT Final 1 and an EMT Final 2. Actually, skip 1. I would like you
Skip
to
one.
do EMT Final 2
Two.
right away.
All right. Sounds
So if
good.
you need to take a break, or I don't know if you're ready to get started, it is timed. So you need to
Okay,
be able
cool.
to sit in one sitting and do it all without any breaks. I want to
Sounds good.
say it's 120. It's either 120 or 150 questions.
Mhm.
But I want to say it's 120. But it is time. You want to sit down and do it all at once. And that will kind of give me an indication of where you stand today. I didn't realize
Yes,
you
sir.
were
Okay.
testing tomorrow. So
Oh.
so that's where I would
Okay.
start today. I wouldn't worry about any more videos or anything. I would just go straight to the final exam.
All right. Cool. Sounds
Once
good.
you finish that, what I want you to do is send me a message inside of school saying, "Hey, coach, I finished it." I will look at your results, and then I'll tell you. You're also going to see it yourself. As soon as you're done, it's going to tell you like your score and all of that. But what you want to do is not only focus on the questions that you got wrong, you want to read the explanation for every single question. Because in those explanations and in the rationales, it's going to teach you the patterns of like the things that keep coming up or how you need to answer the question. Okay. Can you repeat that back for me so I know that you're understanding?
Yes,
Tell
sir.
me what
So
you're
I'll
going to
do
do.
EMT Final 2, and then I will send you my score at the end,
You don't have
and
to
then
send
I
it to me. I'll
will.
have access
Oh
to
no.
it. So all you
Oh,
have to
I
do
see.
is send me a
Okay.
message saying I've done it.
Okay. Yes, sir.
Okay.
And then I will check on the answers I got in
Well, incorrect and correct.
incorrect
You want to
and
read
right. Okay.
the explanation for every single question, because that's going to help you. Even if you got it right, you want to make sure that you got it right for the correct reason, as opposed to it was just a lucky guess. So read the explanation for every single question. It'll probably take you an hour to actually read all the explanations, but that's going to help you way more because it's going to help kind of jog your memory of like patterns you need to focus on. And then
Yes,
once
sir.
you let me know that you've done it, then what I will do is I will go back through it myself. You're going to have the same information that I have. I'm just going to analyze the data to figure out, okay, what are the weak areas? And then maybe we can work on that today.
you.
Wait, what else do I have? Today is Tuesday. Okay, I think we're good. Okay. Did you have another question?
Mm.
Okay. How has the
Okay,
NRMT
so
past study course been for you?
hate that actually.
Okay.
When you
Did
helped
you
it a lot.
finish all 5 days?
Yes, sir. I do.
Okay, good. And you found it helpful?
Oh yeah.
Okay, cool. Did you have another question?
Yes, sir. That had be
Say it again.
I said yeah. No. No, sir.
Okay, no problem. All right, so go ahead and, in fact, you can go ahead and hop off. I want you to get straight into your final exam. Just make sure you have
All right,
no
sir.
distractions. Sit in a room by yourself with no people walking around or anything. And I want you to sit there as if it's like the real thing. So if you want, go ahead and have like one sheet of paper or a laminated thing or whatever, like a sheet of paper is fine. Have one sheet of paper that you could use to like jot down any notes. Just set a timer for 5 minutes and see how much you could jot down in 5 minutes, because that's kind of what you want to be able to do on the real thing. And then make sure your phone is not going to go off. You have no notifications or anything happening. And then, of course, the exam will be timed. Let me verify that that one is timed. It should be, but let me double check something real quick. Let me see. So this is what did I say? I said that is I want you to do final exam number 2. Give me just a minute to find it in the list. Here we go. Final exam 2. It is, oh, wait. Oh, I don't have that one available. Let me make it available. I'm glad I'm looking. So I'm going to make that one available right now. Now that one's going to be available just, that one's just going to be available till, let's say, 5 p.m. Today is the 14th. All right, we'll make it available until, here, I'll make it available until in the morning for you. Okay, but I want you to do it right away.
Right now? All right, I got you.
Okay, you're gonna get one attempt on that one, and that one needs to be timed. All right, how many questions is that one? That is okay, so we're gonna make this one here. I'm doing this right now on the fly for you. Hold on, that one needs to be timed. So let's do. Okay, let me verify how many questions is in that one, because I don't remember. This one has, okay, good. It has 120 questions, so it mirrors the National Registry.
I got you.
All right.
Well, thank you.
Are you able to verify that you have access to it right now while we're online?
Oh yeah, I'll check on that.
Okay. And then Brian, did you have any questions?
All I see is the final exam. All
right, refresh your
the first
page.
one. Refresh. All right. Let's see. Final exam 2. Okay. Yes, sir. I got it.
It is there?
Yes, sir.
Okay. And once you start, it will be timed and you only get one attempt.
I got you. All right.
Okay.
Cool.
Anything else?
No, sir.
All right, cool. Brian, anything from you?
Good afternoon. Thank you so much for your time and going after just being a part of this community and you right now. I shocked myself and I joined this. My question to you is like last 2-3 days I kind of was out of it because I had some foodborne illnesses and I was super sick, but feeling a little bit better today. Luckily I was on my off days. What would you recommend for me to get back on track? I finished like day 1, cohort 1, but I haven't been doing anything else just because I've been out of it with GI stuff and vomiting.
Okay. So you're going to, so when is your exam scheduled?
I did reschedule it and I did do that little thing you said in the very beginning of the lecture. It is
The
August
form?
18th. Yes, sir.
Okay. So when you said your exam is or is not rescheduled? Brian? Brian, you still there?
Here, can you hear me?
Okay, is your exam is or is not rescheduled? All right. If you could just stay unmuted for me. I'm not hearing you,
Okay.
Brian. Okay, now I can hear you. Is your exam scheduled or not scheduled?
August 18th. It is scheduled.
Okay, so August 18th is over a month away. So in this case, what you want to do is just jump right back into the 21-day game plan. So if you're not so sure of the information from cohort 1 session 1, because day 1 of the 21-day game plan is cohort 1 session 1, cohort 1 session 2. So you could literally just start back over, or if you're comfortable with let's say session 1, read the session summary under the video to make sure you know all that information. If you know all that information, go to the next video. If you don't, just go back to rewatch that one video. But you just want to get back on the 21-day game plan. If you've done day 1, your next is day 2. And it's broken down day 1, 2, 3, all the way to 21. And so you want to closely follow that as much as possible every day.
Thank you so much.
Okay,
Appreciate
no
that.
problem. All right, is that it, everybody? All right, we're going to go ahead and end it. And no, Kayla, I'm not calling on you again. All right, Kayla, you're gonna, you're gonna upload this into the community for everybody, right? Okay, do a great job because, hey, I may even get to use this as a video. Okay, all right. Do I have permission to use it? Okay, good. All right, so anything else, Kayla?
No.
Okay. All right. Good job today. And all right, we're going to go ahead and end it for everybody. By the way, tomorrow we do have the first kickoff accountability meeting. Check the calendar for the times, and then Thursday evening we'll have another Q&A. Oh yeah, and so Thursday let's go over ACLS and PAL stuff. That would be a good topic. So I'll go ahead and draw some things out and have that ready for Thursday. All right, everybody. I'll see everybody tomorrow morning, and then I'll see you again on Thursday. Good day, everybody.
Thanks, Coach.
You're welcome.